When you think about Fiji, what comes to your mind? The breathtaking natural sceneries? A wonderful escape from stress and reality? Everything changed when COVID-19 first reached Fiji on the 19th of March 2020.
As of 20th of May 2022, Fiji reported over 64,000 confirmed COVID-19 cases and about 860 deaths. The Fijian government imposed rigorous testing, tracing, as well as other social distancing measures such as business closure, travel restrictions, quarantine, and curfews.
However, unequal distribution of qualified workers, low community response capacity, and frequent weather fluctuation have posed difficulties to the government's health interventions. Among the individuals being adversely affected, vulnerable communities are disproportionately bearing the side effects of the various infection control measures as well as the existing inequality in the system, such as indigenous communities, remote island residents, people with low health and digital literacy, and unemployed population in the tourism industry.
Considering the importance of accurate data on the predictions of trends and adjustments of public health measures, our proposal will focus on updating the existing surveillance system based on Pillar 3, surveillance, rapid response teams, and case investigation, stated in the operational planning guidelines published by the World Health Organization in 2020.
To enhance the pandemic preparedness, particularly for the most vulnerable population, such as resident and indigenous inhabitants living in remote islands, a national pandemic protocol is needed. The health system of Fiji can be strengthened according to the WHO Health System Framework. We hereby propose island health information hubs, each as a solution. It also implies a metaphoric meaning as I help inhabitants here. Since the vast majority of Fijians live in northern, central, and western divisions, they can reach to health service easily with little geological constraint. Each will mainly located in the eastern division, where islands are scattered in remote areas, having limited subdivisional hospitals. A total of 17 each are expected to establish among 4 island groups in the eastern division, 5 in Kandafu group, 5 in Lau group, 6 in Lomafiti group, and 1 in Rotuma group. For this purpose, each pioneer team is needed. They will be responsible for establishing the center, including needs assessment and blueprints planning work. With the activation of NPP, iconic villas and resorts at designated islands will be transformed into each, which will serve multi-purpose usages. Taking Kandufa Island as an example, the Papageno Resort will be transformed to each once the NPP is activated. A part of it will be turned into surveillance center. Health-related information and hotlines, proof accurate and reliable, will be displayed on the LED billboards outside each. This makes sure inhabitants living in remote areas can access to timely and accurate information sources, while important information will also be disseminated through octophone call. Once they encounter any difficulties, they can either dial in or go to each for further advice. Each can deliver community-based health services as well, such as measuring health indicators. The basic health services provided by each ensure all Fijians, including the most vulnerable population, are entitled to health services they need for encountering pandemic. On the other hand, it also maintains a steady employment rate when the tourism industry is severely hit during pandemic. People who work in the hospitality and tourism industry will be employed as healthcare assistants when the NPP is activated. Prior training and education on delivering basic health will be offered to them so as to alleviate the workload of frontline health workers. With geological constraint to hospitals, quarantine and isolation facilities can also be incorporated into villas with a proximity to each, where patients can be quarantined and receive care, preventing an overburdened health system.
It will also improve the current Fiji Emergency Medical Assistance Team, FEMAT, the Type 1 Stationary Emergency Medical Team, established by WHO in 2019, which is responsible for responding domestically, providing medical and emergency services to residents. Current members are the local health professionals who will set forth to remote areas once there is a disease outbreak. But the current FEMAT lacks inter-island mobilization due to understaffing, since all regular members of FEMAT are from the northern, central, and western areas, causing the difficulty in reaching all the remote islands with insufficient medical resources in one go. FEMAT can adopt a model of public health RRT as the mechanism of a larger emergency response strategy that can be utilized in responding to infectious disease fast and effectively. The model contains a non-emergency phase as a comprehensive preparation stage to better cope with the emergency phase and may improve the contingency capability of the FEMAT. We will expand both the core and localized island FEMAT team member size. The former will have more healthcare professionals, government workers, etc., and the latter will have residents from the islands, such as traditional healers, who will be provided with regular training for mastering basic medical skills and providing basic care. Completing the preparation work of each and FEMAT, training and education can be offered to Fijians, especially for those indigenous inhabitants, which helps increase their pandemic and disaster preparedness. Related drills will be also held once a year. The drills offer a chance to prepare for the pandemic outbreak and familiarize with the locations of each, quarantine and isolation centers, the channels to obtain health surveillance data, and access to health information. Once the disease outbreak happens, a multi-destination outreach program will be facilitated. Core FIMAT will set off to join a confluence with the localized FIMAT and Eastern District to offer medical assistance to the residents living in remote islands.
This helped increase the current efficient response to the emergency phase due to the impeded mobilization.
To further improve the health information system, we proposed the Integrated Artificial Intelligence Surveillance System, IAS. In COVID-19, the Fiji government has launched a contact tracing app, Fiji. We suggest expanding its function more than contact tracing, developing it into an all-in-one health information app. One major improvement is the optimization of the data sharing with other health surveillance systems, especially early warning, alert and response system, EWAS. The data was collected by a tailored kit called EWAS in a Box, which contains 15 smartphones and solar chargers. Smartphones are to report symptoms of diseases by localized FIMAT health practitioners, as new diseases that are potential to become a pandemic are hard to predict. A detailed symptom-based surveillance which EWAS provides seems more practical for detecting an unnamed disease. Data should be collected from tourists through Care Fiji and from people living in remote areas without internet access by healthcare workers equipped with EWAS kits. With all data collected from different surveillance systems, abnormal patterns between information could be more easily observed through AI. Under emergency situations, private sectors could report syndromes of suspected cases through the IAS. In remote areas, telediagnosis could be performed using the app by connecting patients and physicians. Daily press and urgent information of the pandemic should be published on the app as well. Also, other pandemic and disaster-related information, health education and promotion messages should be available on the app as well. The system also supports automated analysis, which allows rapid monitoring and response to the potential crisis. Vulnerable population, especially primary industry like fishery, face the problem of food insecurity, unemployment, low income, and insufficient access to social security or other safety nets. These populations are likely to feel isolated from the society. Although our proposal cannot help them directly, we could interview these groups and inform other stakeholders about their adverse situation so as to arouse social awareness towards them. These documentaries could be launched on the app as well.
In order to optimize the effectiveness of the program, we anticipated 3 major challenges and proposed respective suggestions. First, inequalities in densities of healthcare workers between rural and urban areas serves as a major challenge towards program operation. As travel restrictions around the globe reduce the possibility of involving overseas professionals, we advocate the involvement of traditional healers and unemployed individuals working in the tourism industry. With appropriate training on COVID testing and related health knowledge, we aim to build regional capacity to detect, track, and respond to the emergence of infectious diseases. Second, Fiji is highly vulnerable to natural disasters, which increase the difficulty and instability of program management. Climate-related disasters such as flooding may elevate the risk of infectious disease transmission, destroy infrastructures, and hinder the effectiveness of health communication. Hence, we plan to empower the local community with help of EMT. They can assist in promoting disaster risk knowledge and build response capacity among the population in remote areas. Education sections will be designed to be more frequent before the arrival of western and peak tropical cyclone season. Third, the compatibility of devices, insufficient digital literacy, and poor adaptation restrict the effectiveness of contact tracing. The government could propose smartphone subsidizing schemes and seasonal digital education programs in healthcare centers. With the engagement of locals, contribution from EMT, and cooperation with the government, it is believed that our program can build a disease-resilient community.
In conclusion, our activities timeline is shown in this Gantt chart. We divided 2 years' time into 8 quarters, where the first few quarters will be used for establishment of our solutions. Once the preparation work is completed, training and education, Care Fiji app, as well as pandemic preparedness drill will take start. Here comes to our budget plan. 55% of our funding will be allocated to personnel, ranging from each pioneer team to data scientist team, while the remaining 45% will be used for IEs, materials and equipment, and transportation respectively.
We will then proceed to the evaluation part, which indicates how we execute a comprehensive evaluation of resources, contents, and methods before and during policy implementation, followed by examining the impacts and to determine whether our expected results achieve our objectives. And first step, formative evaluation, which is to assess the acceptability and feasibility. We will collect data and information from stakeholders following the CFIR framework, including evidence strengths and quality, population needs and resources, knowledge and beliefs. We will also monitor case amount through Care Fiji app for process evaluation in order to allow appropriate changes before and during the policies are fully implemented. And next step, summative evaluation, to determine whether immediate effects of the program and intended behaviors were sustained in the long run. We will undergo data stratification with qualitative and quantitative data. Quantitative impacts can be seen by the number of population covered by the policies and early warning alert and response system, EWAS, the amount of cases reported, and the mortality and morbidity rates. For qualitative impact, we can measure attitudes and belief of the population by surveys and interviews, such as Likert scale, which is commonly used as expressive degree of agreement or disagreement by responding to attitudinal items. Also, health literacy tests can be used to test population health knowledge.
We will formulate and improve our policies through continuous documentation, monitoring, and evaluation. In the long term, learning from our experiences can serve as the basis of further pandemic preparedness and education material.
We are living in a new health era, and we hope to propose a balance of innovative yet realistic evidence-based solutions based on the Pillar 3 3 introduced by the WHO in order to build and strengthen the capacity of health system in Fiji to better respond to future public health threats among vulnerable populations. Thank you.